Hello, everyone. Welcome to day 5 of the CCIH 2021 virtual conference, where today we are focusing on technology and global health programs. I'm Mona Bormet, Program Director at CCIH. We are so glad you could join us for the conference. And while we look forward to being able to meet together in person again soon, we're very grateful to have this technology to bring us together now. So you have seen a slide of all of the sessions of the conference. The next slide you will see has instructions in French and Spanish to join the language interpretation channels. So if you need that, we hope you take advantage, or if you want to listen in French or Spanish, you're more than welcome to. We will hold all questions until the end of the program today, which will be approximately at 9:40 US Eastern Time. And then after Q&A, we will go into networking and breakout rooms. So we will collect all questions until time for Q&A. You can put your questions in the chat box. We have staff monitoring that. You can also introduce yourself in the chat box. We'd love to know where you're joining from. We're also very grateful for our sponsors who have helped make the conference possible. Our gold sponsor today is American Leprosy Missions. American Leprosy Missions exists to serve as a channel of Christ's love to persons affected by leprosy and related diseases, helping them to be healed in body and spirit and restored to lives of dignity and hope. So we're very thankful to ALM, their mission, and all the work they do in so many different places around the world. You'll have an opportunity to speak with folks from ALM later today. We're also thankful for our additional sponsor today, Chemex Health. Chemex Health breaks traditional barriers with its innovative diagnostic system that expands the potential of diagnostics for emerging diseases, making accurate tests accessible to new locations and new populations. Chemex Health designs diagnostic technologies for the real world by listening to the needs of healthcare providers, including those in some of the most remote and challenging settings, which includes a lot of people that are part of this conference. Well, I'm really grateful to see that more people are joining, and while they are, it is my privilege to introduce our moderator for today's session, Dr. James Duah. Dr. Duah is the Deputy Executive Director of the Christian Health Association of Ghana, CHAG. He is responsible for many things, including administration, policy, planning, monitoring and evaluation for health service delivery for CHAG's network of 343 health facilities and health training institutions. Dr. Duah is the Technical Director for Global Fund Community System Strengthening Program for the new Funding Model 3, for which CHAG is the principal recipient. Dr. Duah is also a member of CCIH's Leadership and Governance Working Group and an overall active CCIH member, for which we are grateful. And I personally really appreciate learning more about Dr. Duah and about CHAG when I was able to visit Ghana in February of 2019, where we did a deep dive to learn more about CHAG's infrastructure in Ghana's healthcare system. CHAG's mission is to promote the healing ministry of Christ and be a reliable partner in the health sector in providing the health needs of the people in Ghana and fulfillment of Christ's mandate to heal the sick. So we are very thankful for Dr. Duah and his work and CHAG and their work. And I'd like to turn it over to Dr. Duah to lead us through our session on unity and technology today. So over to Dr. Duah, and welcome everyone.
Right. Welcome. I'm James Duah. If you are new to CCIH, we are an international network of nearly 120 organizations and 15 secular partners, as well as a few hundred individual members, most of whom are based outside the US. CCIH's mission is to promote health and wholeness from Christian perspective, and we provide opportunities for capacity building, networking, sharing best practices, and advocacy. This session is being recorded and will be posted on the CCIH YouTube channel in the conference playlist, and you will find links to recordings on the CCI website at www.ccih.org under events. I'm happy today that we are talking about technology. A year ago, a gentleman and his wife and son walked to my house in the evening. And in the community where I live, nearly everyone knows me as a medical doctor. And at the time, I saw this young man having difficulty in breathing. And before he could explain himself, I knew what he was coming for. If you are a medical doctor and someone walks to your house or office at that odd hour, you can probably guess what he's coming to look for. And so before he narrated his story, I took his national health insurance card, which almost everyone has in Ghana. When I looked at it, I saw that the card had expired. But I remembered from our previous interaction with the National Health Insurance Authority that they had introduced a new system that allowed members to renew their cards via mobile money. And so quickly, without asking further questions, I had to dial *929#, which is the code for renewing insurance cards. Ladies and gentlemen, the gentleman asked me for money to go to the hospital. And before he ended, I said, I have renewed your insurance card, so you can go to the hospital. I proceeded by calling a colleague at the hospital who said, okay, let him come. And so technology saved me from embarrassment, saying that I don't have cash at home. But more importantly, it allowed me to connect this person, who's a community friend, to the health system. Technology continues to offer a lot of opportunities for the faith community, and I'm delighted today that we'll be talking about unity in technology. I'll go ahead and introduce our first speaker for today. So for some of you who know Ghana very well, we have three most influential offices that are occupied at the moment that are headed by women. One is the Chief of Staff, who coordinates presidential affairs for the entire country. The second one is Food and Drugs Administration. And the third and the most important one is the National Health Insurance Authority. Important because it borders on the very core of every Ghanaian. And ladies and gentlemen, I am happy to introduce to you our first speaker for today, who is Dr. Lydia Dsane-Selby, the CEO of Ghana's National Health Insurance. Dr. Selby is an ENT specialist, a medical doctor who worked in Kolebu Teaching Hospital before going to the UK, where he specialized as an ENT surgeon. And ladies and gentlemen, working in National Health Insurance Authority, he's brought many changes, which HAG and many other organizations are very proud of. So I'm happy today to be talking with Dr. Lydia Dsane-Selby, one of the influential women in Ghana. Dr. Selby, welcome.
Thank you very much, and thank you all for inviting me.
Great. So can you kindly tell us about Ghana's health insurance scheme for the many people who have joined us to know a little bit about Ghana's experience with national health insurance?
Thank you very much. Ghana used to have free healthcare, but got into financial difficulties and began to charge cash at point of service, which was nicknamed cash and carry. And as you can all imagine, this caused a lot of distress, where you are asked to put money down before you are cared for, even when sick. So in 2003, a law was passed establishing the National Health Insurance Scheme. It has dedicated funds. 90% of it is tax-based or from the government. We have a special health insurance levy. and a certain percentage from the formal sector's social security, and an annual premium, which is just a token, and very targeted exemptions for the poor and the vulnerable to ensure there's equity. And these funds are pooled for people to be able to access services free at the point of care. And we contract with providers, and the National Health Insurance Scheme pays the bills. So that is, in a nutshell, is what the health insurance scheme is all about. We cover outpatients, inpatients, diagnostics, medicines. Obviously, we have an exclusion list for some of the more expensive diseases, which we will gradually try to cover. And the exemptions are for pregnant women over 70s, under 18s, and anybody that the Department of Social Welfare considers needs help is given a National Health Insurance card for free. Right. It has its challenges, but we're working on them.
Right. So, Dr. Selby, how are faith-based organizations engaged in that system in Ghana?
Well, a lot of countries, when they start, tend to work with the public sector only because it's easier to administer. But somehow Ghana took the plunge and went for public, private, and faith-based organizations. So as long as you meet the national standards in terms of personnel, equipment, and quality of service, you are contracted with the National Health Insurance Scheme. We have over 300 faith-based providers working with the scheme, and they run from health centers to clinics to primary hospitals to secondary hospitals providing specialist care.
Thank you. So I've seen that over the past 2 years, there's unprecedented enrollment in the National Health Insurance. What is driving that high level of enrollment?
Thank you for that question. And it's something I think we're quite proud of. We had a challenge with keeping our members active. Ghana has a population of about 30 million. We had managed to gradually increase enrollment, but keeping people active was a problem. We did a couple of researches, and one of the key things was it takes too long to renew at our district offices. Anecdotally, people were queuing up to 11 hours a day to renew. And even though we had close to 170 offices across the country, it obviously wasn't enough. So we decided we must find another way, a partner, to work with us. Using the design thinking method, our members made it clear they wanted to self-renew. And the best way was through mobile technology. Everybody in Ghana has a mobile phone. So we quickly came up with an application that would allow people to renew using mobile technology themselves. And this project was to take 2 years, but we were ready within a year because it kind of just developed itself. The challenge, of course, was that the dates on the back of the card would no more be there. So we had to find a way for providers to be able to authenticate using mobile technology as well. And there have been so many spin-offs from this technology that has helped us. We're planning, the Vice President launched it 2 years ago. We're hoping that within a few years, we'd have 50% of our members renewing by mobile technology. Within 6 months, 75% were doing so. And in some districts, 90% of renewals are by mobile technology. So it obviously was something that resonated with the public. It works on feature phones. It doesn't have to be an Android phone. Didn't cost a lot to do. We are able to administer the databases ourselves within our own authority. So it's been a win-win all round.
Highly commendable. I think CHAG is a beneficiary, and myself, I'm a beneficiary because it saved me the embarrassment of having to pay cash to somebody. Thank you for that. But how has that improved access to health services, including faith-based health services?
Well, it has increased our membership tremendously. So we were hovering around 40% of the population, and over the last year, it's jumped to 52% active membership. And with the sort of total registration, we've now close to 78% of the people in Ghana have NHIS membership. So it has helped us a great deal within the last couple of years.
Right.
Obviously, access to service depends on being active. And the peculiar challenge of the faith-based providers is the fact that your Christian principles make it difficult for you to turn patients away. But however, healthcare is a business. You have to run. So you can see the dilemma of, do we treat, they are not active, do we ask them to pay money? This, I think, is going to help make sure people stay active so that the faith-based providers will generate enough income to keep running without having to break their Christian principles of asking people to pay money when they are sick.
I see a lot of countries are actually advocating for universal health coverage. What do you think we should expect to see when more countries drive the universal health coverage agenda?
Well, I think for me, it's such a fundamental, almost human right. We've all been ill when we know that that is not the time when you should be worried about how you're going to pay for the healthcare. So we have to find a way to convince all countries that however you gather the money ahead of time and pool the resources, it must be done so that at the time you are ill, that is not the time when you must be worried about finances. It could even slow down your recovery. The other thing is there's inequity in finances. We are not all the same, but health and I believe education, we should all have access to the same thing. The best way to do it is with UHC, where you have pooled resources. We cross-subsidize each other. That is the purpose of health in UHC. It doesn't have to be through an insurance like Ghana has done, but there must be a way of having dedicated funds that are pooled so that all of us are equal when it comes to healthcare services or accessing healthcare. UHC
are you paying for capital improvements or technology in Ghana?
Well, in Ghana, the issue is capital improvements has funding from the main government budget. So at the moment, the health insurance, which was built to take care of out-of-pocket expenditure, does not capture that. But it's something that as we continue to evolve and our health sector evolves and reforms and restructures itself, you may find that the health insurance takes on some of that as well.
I know that governments are challenged, and especially in Ghana, where we have all funds going into one account. I mean, when funds are collected, especially in Ghana, are there any tensions about how they should be used? What's your experience on that?
I think there's always tension when money needs to be shared. In Ghana, the tax component, the levy by law, goes into a consolidated fund, and so does the SNIT, the Social Security collections from formal sector. But we keep extremely accurate records. If you don't give it to us today, trust me, you'll give it to us tomorrow or the week after. So we keep excellent records in that regard. Obviously, we work in a macroeconomic situation, and at any time T, there's a lot of competition for those funds. But I do think that it has been recognized by successive governments that the health insurance is so important to the health sector and therefore the health status of Ghanaians. And they do make an effort to make sure monies are released. We have bipartisan political will. So I think that has been one of the driving forces behind what Ghana has achieved, in that the political will, irrespective of the change in government, the political will for the health sector is always there, and that is key.
Well, having the benefit of being a Ghanaian, I think I must commend you, because I've seen that payments this time has improved significantly compared to previously. Now, if you were to set up insurance system for other countries in Africa or elsewhere, what would you do differently than what Ghana has done?
I think first and foremost, every country is different, and we cannot say that health insurance is the best for every country, social health insurance. But rightly or wrongly, I'm not sure I would do any too much different, at least for what we have on paper. The challenge we have in Ghana, and I think quite a few African countries, we put things on paper and then don't implement what we've put on paper. And I think that's one of the challenges we're facing. But I think whichever way you go, you must pool the funds. There must be cross-subsidization. It must be earmarked in a way that successive governments cannot interfere without going through a laborious process of amending and repealing laws. So what you do must be backed by legislation to protect the public as much as possible. And as I said, political will. Any country wanting to reform your health sector, political will is so key. Health is an emotive subject. It tugs at everybody's heartstrings. But sometimes you have to also look at evidence and take decisions that may be tricky sometimes, always having the emotions at the back of your mind because of the factor it plays in the well-being of the public.
Well, finally, tell us a little bit about your own faith and how that influences your work. Any advice for the many participants in this conference?
Thank you very much. I think I am an Anglican. I was confirmed at the age of 11 when I was living in the UK, and I belong to one of the interdenominational churches in Accra. COVID has affected communal worship, and I think that that is something we're all facing, and hopefully we can get back on track soon. I miss attending Mass, early morning Mass. But I do believe that faith plays a large part in success. I think I have read a few research papers which showed clearly that surgical teams who pray and before their operations and have a strong faith, irrespective of the religion, have better outcomes than those who don't. It's not everything that the human mind can understand, but I think health, as I say, is an emotive area. It really affects all of us, our well-being. And when healthcare professionals have that added weapon or armor of faith, I think you do that much better in the way you interact with patients, and therefore you come with a better outcome, better results. And one thing I would say that in this era of a very money-driven world, where finances and wealth control our everyday lives, we need to remind ourselves why we came into the health profession. We didn't really come into it to be super wealthy. We came into it to help others. And much as we need to run financially sustainable businesses, I would plead with all health workers across the world, let's also remember our faith and our Christian principles and why we became health workers in the first place, if we want to make a difference in the world. Thank you.
On that note, I want to thank you very much, and I can attest to your faith. I remember many years ago, you came for clinical audit, and in spite of everything, you said that you are underbilling. You need to be paid this. For me, that was an example of a Christian leading audit. Many thanks, Dr. Lydia Dsane-Selby, one of the influential women in Ghana. Thank you very much for your time with us this afternoon.
Thank you very much for having me.
Ladies and gentlemen, that's Dr. Lydia Dsane-Selby from Ghana, CEO of National Health Insurance, one of the best social interventions that happened to Ghanaians. At this point, it's my pleasure to introduce the next speaker, who is Adams. CCIH and all our global network depend on strong connections within donor agencies, including the USAID. It's very helpful to us all to be able to reach out to the faith-based office. This office now sits within a larger hub that focuses on localization and new partnerships as well. CCIH has engaged with Adam Phillips, who is the director of the Center for Faith-Based and Neighborhood Partnerships at USAID. The Partnership Center at USAID is working to strengthen democracy and stand with others on the path towards self-reliance and resilience, in addition to addressing the global COVID-19, climate, and human rights crisis. For 2 decades, Adam Phillips has served as pastor, movement organizer, and strategist, working at the intersection of faith and public life, leading inclusive and multi-faith mobilization effort for the One Campaign, Bread for the World, World Vision, Union for Affirming Christians, and Faith 2020. Mr. Phillips has provided us with a video greeting today on the importance of strengthening locally led organizations through USAID partnership and how we can leverage the focus on strong, resilient health systems beyond the current COVID-19 crisis. Ladies and gentlemen, we have a video from Adam Phillips.
Good morning, afternoon, and evening, everyone. My name is Adam Nicholas Phillips, and I'm the director of the Center for Faith-Based and Neighborhood Partnerships and of the Local Faith and Transformative Partnerships Hub at USAID. Thank you to Doug Fountain and the Christian Connections for International Health for inviting me to make this video address. USAID and CCIH have a long history of cooperation and collaboration, and I'm honored to continue that tradition. Prior to USAID, I spent my career as a pastor and a grassroots advocate, championing inclusion and service to and with the poor. Through my work at the One Campaign, World Vision, Bread for the World, and many other faith-inspired initiatives, I've witnessed the tremendous impact that religious leaders and FBOs can have in healing communities in need. At USAID, I want to champion that work by continuing the 20-year legacy of the agency's faith-based office to build bridges between the federal government and faith communities. Working at the intersection of faith and action has given me extraordinary privilege to forge relationships with humanitarians, activists, and development professionals across the religious and political spectrums. I've seen firsthand that we can do amazing things together. So I'm inspired not only by inclusion, but by courageous acts of unity. Partnership offers us the chance to model a new paradigm, that embracing pluralism and advancing development goals, we can heal divides not only in our nation, but also in our world. Turning to the topic of today's event of unity, I want to share the various ways in which the US government is working cohesively to enhance global health. USAID's Bureau of Global Health works in harmony with the Department of State, Department of Health and Human Services, Centers for Disease Control and Prevention, National Institute of Health and National Security Council on every global health topic from COVID, polio, malaria prevention, ending tuberculosis, vaccinating children against measles, and more. For 60 years, USAID's global health programs have saved lives, protected people most vulnerable to disease, and promoted the stability of communities and nations while advancing American security and prosperity. America is safer and stronger when people can live healthy and productive lives, and when nations around the world are self-reliant and resilient. USAID's global health efforts, grounded investments in health system strengthening and breakthrough innovation, are focused around 3 strategic priorities: preventing child and maternal deaths, controlling the HIV/AIDS epidemic, and combating infectious diseases. Which brings us to COVID-19. On COVID-19, the US government is working to provide critical resources, including technical assistance and funds for accelerating equitable access to global COVID-19 vaccinations, thereby controlling the pandemic where we can and slowing the emergence of new variants. The US has committed an additional $2 billion out of a total planned $4 billion to the Gavi COVAX Advanced Market Commitment, otherwise known as AMC, to provide safe and effective COVID-19 vaccines for 92 low and middle income countries. USAID and the Department of State, in partnership with Gavi, the Vaccine Alliance, and recently co-hosted the COVAX One World Protected event, launching an international campaign to raise an additional US $2 billion for the collective fight against COVID-19. In total, the event raised $386 million. And additional funding from donors and countries with multilateral donor bank support will enable the Gavi COVAX AMC to secure 1.8 billion doses of COVID-19 vaccines for participating countries by the end of the year. Through partnership and support to the Access to COVID-19's Tools Accelerator, the US government is also helping to expand global access to COVID-19 therapeutics and diagnostics. The COVID-19 pandemic has shown us how infectious diseases threaten all of society, upending people's lives and attacking societies at their cores. While the ongoing pandemic has created unimaginable loss, hardship, and challenges, it has also forced us to recognize the critical nature of investments in disease detection, prevention, and preparedness. When a health crisis like COVID-19 strikes, governments spring into action. When the crisis fades, urgency often turns into complacency. Investments shrink, attention shifts, and a false sense of security ensues until the next emergency. This cycle of crisis and complacency needs to be replaced with continuous support for detection, prevention, and preparedness that leaves countries better prepared to protect lives and economies from future infectious disease threats. Epidemic and pandemic preparedness and global health security are top national security priorities for the Biden-Harris administration. President Biden has stated, quote, "We must simultaneously work to finance health security, strengthen global health systems, and create early warning systems to prevent, detect, and respond to future biological threats, because they will keep coming." This current moment presents a unique opportunity to galvanize all of society, public, private, and civic sectors, to come together to prepare for and hopefully prevent the next pandemic. USAID is utilizing its vast experience, resources, technical capabilities across multiple sectors, and strong relationships with partner countries to help prevent avoidable outbreaks, detect threats early, and respond rapidly and effectively when outbreaks occur. Now, turning now to another critical health issue, HIV/AIDS. USAID is the key implementer for the President's Emergency Plan for AIDS Relief, PEPFAR, which is a US government multi-agency collaborative program led by the Department of State. As of 2020, through PEPFAR, 50 million people received HIV testing services, 17.2 million people were on life-saving antiretroviral treatment, and 290 million healthcare workers were trained, significantly contributing to the goal of achieving global HIV/AIDS epidemic control. During the COVID-19 pandemic, USAID is leveraging HIV and other long-term health investments and assets to institutionalize programmatic adaptations that will be the cornerstone of mitigating the impact of COVID-19, and are well positioned to strengthen health systems and advance broader global health security. As part of the American Rescue Plan Act of 2021, PEPFAR will receive $250 million to use toward the delivery of HIV/AIDS commodities and COVID-19 responses, as well as efforts that align to the broader USG global COVID-19 response and recovery strategy, objectives, lines of efforts, and associated metrics that are being developed within the US government. USAID's new 10-year vision for health system strengthening 2030 emphasizes the roles that communities, the private sector, and public health play in creating stronger health systems, and that enabling local organizations to identify and drive solutions is critical to achieving equity, quality, and the most efficient use of resources in the health system. All sectors of a society have a role to play in their health system and can bring resources to the table that may be overlooked, such as influence over behaviors and social norms or processes and technology that improve the quality of care delivered. The vision also recognizes that locally designed approaches often offer the most effective solutions for delivering higher quality healthcare to the populations in disadvantaged and vulnerable situations. In addition to the vision, USAID's forthcoming local capacity development policy is one among many efforts to work more closely with local actors to support local ownership and ensure that local actors are in the driver's seat. It is precisely these populations that we cannot lose sight of in our pursuit of more resilient health systems and broader health security. As we look at ways to build back better from the pandemic, we must consider whole of society approaches to our development assistance. In conclusion, USAID works every day on behalf of the American people to promote and demonstrate democratic values abroad and advance a free, peaceful, and prosperous world. I'm proud and honored to represent the agency's office that works to build inclusive engagement with diverse faith-based organizations and communities. Thank you again for hosting me and listening to this message. I hope next year we can be together in person. And in the meanwhile, please sign up for our newsletter and feel free to send me and my team a message at cfbnp@usaid.gov. Again, you can send us a note through email at cfbnp@usaid.gov. Thanks so much. Stay safe. Peace.
Thank you very much, Adam Phillips, for that video. We recognize the immense contribution of USAID to many of our partners represented here and across many countries. We thank God for your present office, and we know that God has positioned you there for a purpose. Thank you very much. Now, ladies and gentlemen, I would like to introduce to you our next speaker, Dr. Sunil Anand. Dr. Sunil Anand is the Asia Regional Director for American Leprosy Missions, popularly known as LAM, as many of you know. He leads the LAM's work with a network of partners in Asia to research and implement innovative and scalable programs to stop leprosy and other morbidity due to non-tropical diseases and improve the well-being of affected people and communities. Dr. Anand is a dermatologist, nephrologist, and reconstructive surgeon who has over 35 years of clinical and field experience in leprosy. Ladies and gentlemen, we have Dr. Sunil Anand to give us a presentation. Dr. Anand, welcome.
Thank you, Dr. Duah. Hello, everyone. It's such a privilege to be at this virtual conference. Thank you for the opportunity to share our experiences through the presentation that I'm going to make over the next few minutes. Since 2018, American Leprosy Missions, or ALM, has had the privilege of partnering with Leprosy Society India, the Health Informatics Rapid Design Lab at the Indian Institute of Public Health in Hyderabad, and communities with and at risk of neglected tropical diseases through a unique integrated WASH and entities program. What I'm going to present today has evolved through this work and represents our combined belief that we need to bring essential, basic, primary healthcare to the doorstep of people and not the other way around. DHARA is a Sanskrit word meaning constant flow. And in our case, DHARA WL2 is an acronym that stands for Digital at Home-Based Artificial Intelligence-Enabled Real-Time Appropriate Interventions for WASH, Leprosy, and Lymphatic Filariasis. These two high morbidity entities are closely associated with lifelong disability and consequent stigma and discrimination, and are high endemic in India. Next slide, please. There are basically three issues around primary healthcare delivery: accessibility, adequacy, and efficiency. In India, one primary healthcare center caters to about 50,000 people, and often these centers are far from affected people's homes, and therefore they are inaccessible. Neglected tropical diseases being of low public health priority, inadequate service provision is the norm, and therefore of low utilization of such services, even where they may exist in some form or the other. There's also the cost factor involved for those accessing services. Cost of travel for self and accompanying persons, loss of daily wages, etc. So we hope that DHARA is envisioned as a solution that can deliver primary care comprehensively and economically at home. Next slide, please. Next slide, please. Yeah. What would an ideal digital solution look like? A desirable digital solution would be a platform that integrates several needed services like healthcare, water, sanitation, financial aid, etc. With high smartphone penetration across many countries, it would be smartphone based for ease of use. The software would be user-friendly for semi-literate and digitally less illiterate grassroots level healthcare personnel, which would largely be icon-based and therefore language neutral. It would facilitate screening, disease management based on AI-led disease grading and delivery of first-line care. It would also in real time enable care at the point of need, that is the person's own home. Next slide, please. So DHARA is one digital platform that helps in screening, grading, and managing WASH and entities. It has three major components: an icon-based module, a photo-based computer vision module, and a GIS module. These serve various functions as listed on the screen. As a modular platform, it is designed to accommodate several healthcare services. The collectors of the data, who are trained local women, will be the immediate users of this data, supporting people affected through AI-guided real-time interventions. The technology will enable them to support national programs in continuing NTD awareness, prevention, treatment, morbidity management, and surveillance, relevant even in the face of COVID-19 related restrictions. Additionally, the data they collect will enable disease mapping, risk profiling of households and communities, and evidence-based reporting advocacy to facilitate formulation of strategies and policies for NTD endemic resource-poor areas. Next slide, please. This is just screenshots of the digital platform. That here in this slide we see WASH related information data collection. You see stagnation or water stagnation, garbage, water collection, water storage, etc. Next slide, please. These are again screenshots of the platform where you see data collection for lymphatic filariasis. Next slide, please. The platform, DHARA platform itself, is designed to support several modular microservices, 5 subsets of which are actually seen on the screen: a disease subset, disability, nutrition, WASH, and socio-demographic and economic mapping. All of these contribute to the continued transmission and consequences of entities, and all need to be addressed for a holistic approach to ending disease. Next slide, please. So DHARA is a single platform that will screen for several indicators. For example, it will screen for socio-economic demographics, it will screen for WASH issues, it will screen for nutrition, it will screen for disability and disease. And in real time, provide risk profile status of the household, link individuals to appropriate social benefits, provide health information guidance and first-line treatment, and if necessary, livelihood options. And in the near future, we hope to provide telemedicine connect and appropriate facility referral. Next slide, please. So what are the outcomes envisaged through this digital platform? One is that we hope that it empowers people at the point of maximum need. It also provides precise individual service at home, connects services to decision makers with automated analytics in real time. The project is an effort to empower trained grassroots level healthcare personnel by digital upskilling. DHARA proposes highly reliable geotagged fast screening method. By enabling real-time interventions and decision-making at the point of need, this digital platform can provide hope and real service to the affected and at-risk communities on the ground, both reliably as well as sustainably. This task shifting and empowering builds local capacity, ownership, accountability, ensures sustainability, and improves outcomes for people affected by and at risk of entities, because it is targeted at the level of maximum impact, which is at the household level for people who are at risk or directly affected by neglected tropical diseases, and at the policy level with reliable household data for policymakers. Next slide, please. And so that's DHARA, and that we're happy to share this, our experience with you, and thank you very much for listening.
Well, thank you very much, Dr. Anand. That's quite a lot of good work. It's not surprising you have over 35 years working experience in the field. I think this is something that all the systems will need, especially seeing that WASH in healthcare facilities and neglected tropical diseases are things that we need to bring to light. Thank you very much once again, Dr. Anand. And now, ladies and gentlemen, our next speaker is Paul Frank. Paul Frank is the Executive Director of SailLead Inc. and an advocate for the development and translation of health information into local languages. He is also a master trainer for Bloom Software. During this COVID, he put together a comic-style book in Bloom that has been translated into 114 different languages, showing the power of Bloom, but also global collaboration. It's my singular honor, ladies and gentlemen, to introduce Paul Frank. Paul, welcome.
Thank you. I appreciate this chance to share with you today. If we could get to next slide, please. And the next one. If you know anything about SIL Lead and SIL International, you know that we're about languages. We're particularly concerned about underserved languages. Normally, they're local languages spoken in a local area, but not always. Sometimes languages that are underserved have many speakers and are spoken in wide areas. But primarily, we're concerned about the people who speak these languages. Next slide, please. Early in the pandemic, as SIL said, millions of people who speak lesser known languages don't have a single resource on COVID-19 yet. The information gap is enormous and lives are at stake. Based on this reality, one of the very first things that SIL did was to put out a call to action to translate the simple phrase, wash your hands, into as many languages as possible. Some versions were done using machine translation, and then most were translated by people. Next slide, please. As a result of this initiative, eventually this phrase had been translated into 653 languages all around the world, not just major languages, but also minority languages as well. And people could, at the website, download a poster with that phrase on it, and even in some cases, order a t-shirt with wash your hands in the language of your choice. So a very small thing, but our first effort we made to begin to get information to people who needed it. Next slide, please. Personally, early in the coronavirus pandemic, I was trying to think what I could do to help. And I came across this book on COVID-19 by this Chinese artist, Weimin Ko, who provided comic-based basic information to people about how to protect themselves. So I took this comic book, this comic style information by this artist and put it into our Bloom software. Now, Bloom is free software that speakers of under-resourced languages can use to create books in their own language. But another thing you could do with Bloom is to create a master book in a well-known language and then use that as a springboard to facilitate translations into additional languages. Next slide, please. This challenge was taken up by people in many different places, and eventually 114 translations of this one book were created. By creating the master in a well-known language, people could take that and add the text that corresponds in their language and in their script. And this enabled us fairly rapidly then to begin sharing information in a kind of a visual and text form with people all over the world. Eventually, the COVID collection of books in the Bloom library online has come to have 272 different books in 189 languages. Next slide, please. Because of our focus on languages, we started to look to see who else might be publishing information in languages about COVID-19, and not just the international or national languages. We were pleasantly surprised to find that many people were doing that and started compiling an index of resources in different languages. To date, there's more than 5,000 resources that have been identified in more than 1,000 languages in 155 countries. Next slide, please. You can browse this index by looking by language, alphabetical by language, by the primary country in which the language is used, and by the organization who's responsible for it. If you want to find this index, go to SIL's website and look at the COVID resources. Next slide, please. I have a few reflections on this experience. I realize that at least 1 in every 7 languages in the world have resources about COVID related to COVID-19, which is really quite incredible. Another thing that we're pleased to see is that many organizations have woken up to the critical nature of language in communicating essential health information. Now, I don't actually have any data to back this up, but my guess is this small body of information about COVID-19 may represent the body of public health information that has been translated the most quickly and the most widely in all of history. And that encourages me as people begin to gain this critical information in their own language. Finally, this won't be the last, this wasn't the first and won't be the last time the world faces this type of health crisis. SIL Lead and SIL International are ready to work with you and others in order to confront the challenges related to language and health in health generally and in critical crises as well. Thank you for listening.
Congratulations. How do you say wash your hands in your language? In Ghana, we will say Ohronsa, and many people will be quick to add Fasemuna Kahu. To wait, wash your hands, add soap. Thank you very much, Paul Frank. We encourage all of you to put your questions in the chat box. When we are done with the presentations, we will attend to all the questions. Once again, thank you very much, Paul. for the great and incredible work that you have done on washing of hands. Our next speaker is Andrea Kaufman, who is the World Vision's Director for Faith and External Engagement, building networks and coalitions to collaborate for and with children. Ms. Kaufman is passionate about the unique and essential role of local faith communities for sustainable global humanitarian development and advocacy work. Her experience includes grassroots development, partnerships with local faith actors, communications, program design, management, and evaluation. She has also had the opportunity to learn from and with channels of hope practitioners and facilitators around the world. Ladies and gentlemen, help me welcome Andrea Kaufman. She will be presenting on faith and WhatsApp, leveraging technology to listen, learn, and support community health for children and communities in COVID-19. Andrea, welcome.
Thank you so much, Dr. Duah. It's really good to be with you all. I have learned so much listening just this morning. And I'm really looking forward to sharing a little bit about what we've learned over the past year and a half or so about the power of faith leaders to fight a pandemic with WhatsApp as a really interesting and exciting tool. Next slide, please. So if you are anything like us, you've been talking about the possibilities and potential of technology in your grassroots community development work for a long time. And if you're anything like us, you've had some fits and starts, maybe tried some things, maybe made some assumptions about what would and wouldn't work, about accessibility, about technological literacy, and some of the potential barriers. And if you're like us, COVID-19 required a lot of those things to be thrown out the window overnight as we were forced into a virtual engagement reality in order to continue our relationships in communities and continue our conversations with our grassroots community partners. And one of the things, if we've learned anything over the past year or so, it's that WhatsApp and other low bandwidth virtual platforms have really been essential to build and maintain relationships with our faith partners, to listen and to learn and to really understand what's going on in a local community, to offer and share real-time learning, and even to kind of serve as a catalyst for virtual training and workshops. And for us, that has allowed accurate information to be shared. It's combated misinformation and really responded to the unique vulnerabilities of children and communities. Next slide, please. So at World Vision, one of the things that we have done for a while, whenever we have a training with pastors and other local faith leaders, we've set up an informal WhatsApp network that's been leveraged after the fact, kind of as a peer learning and mentoring resource. Different trainings, kind of the quality and busyness of those WhatsApp networks vary quite a bit. 20 to 40 faith leaders, they share information, they celebrate with each other. And we saw, even before the pandemic was declared, those WhatsApp networks were already buzzing. They were sharing information with each other. They were asking questions. What is COVID? What's going on? What are you hearing in your community? And we started to be able to share messages across as new things were coming down. And what started as a network of about 8,000 faith leaders, we saw reaching between 80 and 250,000 as the network extended out. And I think one of the exciting things is these platforms allowed for very kind of regional, contextualized pieces of information. And they also allowed for very globally relevant messages to be shared across the entire network at one time. We could listen, we could learn about what people were experiencing and support. Next slide, please. So as we were kind of having these ad hoc conversations, if you will, with some parts of the group, we started to wonder, is there a way that we can kind of get a global perspective to understand how we as a global international development organization, is there something that we can do that we can respond to that will provide a lot of support for a lot of people? And so we reached out across the full network through a WhatsApp survey in partnership with the University of East London. We asked about our relationship, how things were going between us and our partners. We asked about what faith leaders were seeing as the primary needs in their community. We asked about the role they were already playing in health and humanitarian services in their communities. We asked specifically about spiritual support and the role that was playing. And then finally, just kind of some of the logistics. What kind of messages are you sharing and to who and how? And we had an opt-in survey, went out, more than 300 respondents from 40 countries, more than 5 different languages, answered both simple survey questions as well as open-ended questions where we were able to glean some more qualitative understanding. And next slide, please. So what did we learn? So this, again, the survey took place last year between May and July. We had participation pretty globally. You can see all the countries here. And first and foremost, from a health perspective, we learned that almost 80% were sharing, preaching or teaching about COVID specifically. Most were getting their messages from the World Health Organization or their local ministries of health or other kind of health organizations. So they were sharing accurate and good information. Over half were actually going out of their way to identify and correct misinformation within their communities and networks. You won't be surprised to hear that faith leaders also had a very kind of holistic approach to what they were sharing. They looked at health, emotional, spiritual needs, all kind of in one package as they were communicating to their communities. And many went out of their way to talk about the importance of scripture and sharing wisdom and encouragement scripture for their communities. Next slide, please. Go ahead to the next one. Thank you. So last fall, October, November, December, we started to hear a lot coming up through these networks about the vaccine in particular. People were getting hit with a wall of information, trying to ask questions, trying to figure out what was true, what wasn't, wrestling through ethical questions, theological and faith-related questions, as well as just trying to find facts about the vaccine and the science behind it. And essentially our global faith partners were asking, can you provide us with a resource or a tool that we can use to learn and then to share information with our communities? And so we launched something that I think a year and a half ago we never would have thought was possible, a fully virtual training and workshop designed for pastors and faith leaders, many coming from very rural areas, many attending virtual training for the first time. And we've learned a lot. We've had a lot of opportunities to try out different things like Google Forms and remember where the emoticon buttons are on Zoom and breakout sessions and all kinds of things, teaching on the fly. And I think what we've learned, to go to this final slide, is a few things. One, that technology, well, something maybe we knew before, it's been confirmed. Technology can be an incredible, vital asset for our work. It can help us strengthen and maintain relationships that we have when we aren't able to meet face-to-face. It has the potential to reach or extend our impact as we can listen and learn even when we're not together. And then there's challenges. As we've all experienced many times, technology can fail. sometimes if you're in the middle of a tough conversation, trying to understand kind of the faith-related barriers or ethical barriers related to vaccine, it can be tough, right? But there's also the possibility of additional disparities as we consider how do we reach the most vulnerable communities. And I think a big question is as we move into a post-COVID world, what's the balance going to be? How are we going to determine how much we do virtually? How do we continue to build and strengthen relationships in communities while also leveraging the scale and possibilities that technologies allow? We know we can do more for health and well-being of communities with technology than we ever anticipated. But how will we continue to use it to listen and to learn, to build community and relationships committed to serving the world's most vulnerable? Thanks.
Thank you very much, Andrea, for the insightful presentation, Faith and WhatsApp. It reminds me many years ago when I had a topic, God and Guinness. But faith, obviously technology has helped a lot. In Ghana, when we had lockdown of churches, the fear was that many people will not come together until many of the religious leaders started using WhatsApp and organizing churches and sending the videos and audio messages via WhatsApp. And so for a population that has a mobile penetration of about 138%, they are quite able to reach quite a number of people. On that note, I want to thank you very much, Andrea, for the presentation. I know that there are many questions for you. I will encourage everyone to put your questions in the chat box. We have saved some amount of time. We will give opportunity to address those questions, especially for the presenters that we have so far. So ladies and gentlemen, I think it's been good so far. All the presenters have given us good information that we have so many questions to ask. Our next presenter is presenting on telehealth, and he is in the person of Dsane-Selby. I hope I got the name right. So Dsane joined Cure in Kenya in 2015 in the position of Cure Kids Coordinator. In his role, he was charged with storytelling to help connect donors to patients in the hospital. Later, Dsane moved on to the role of Donor Relations Manager, where he was in charge of all donor-related projects and external and internal organization communication. Mr. Dsane has now graduated to the position of Development and Programs Manager at Cure Kenya, where he currently oversees all fundraising, marketing, and IT portfolios of Cure in Kenya. He holds an engineering degree from Makerere University and is currently pursuing MBA from Strathmore University. Ladies and gentlemen, help me welcome Dsane-Selby, who is going to present to us this afternoon on telehealth. Dsane, you are welcome.
Thank you, Dr. James, and it's an honor to be talking to everybody at this conference. So I'm going to be talking about telehealth, and to be specific, I'm going to speak about the adoption journey of telehealth at Cure Kenya. Next slide, please. And just to give some context onto who Cure Kenya is, Cure Kenya is a hospital that was established in 1998. We're 23 years old. We serve children living at the risk of acquiring a disability. On average, every year we see about 16,000 patients, and we do about 2,000 operations. And among the services that we offer at Cure Kenya, we have pediatric orthopedic and reconstructive surgery. We have physical and occupational therapy, and we do offer mobility assistive devices. Training and research are a big part of what we do. Spiritual ministry is anchored to everything we do. And lastly, we have a mobile clinic and outreach program that is a big part of our operations. Next slide, please. To be able to just understand how we've integrated telehealth and our outcomes, I'm going to take you through what the clinical patient journey looks like for a patient at Cure Kenya. And that patient journey can basically be subdivided into 4 general phases, with the first phase being mobilization and screening. And with mobilization and screening, we have the mobilization part, which happens through 3 distinct ways. And one of that is healthcare education. And we do have referral from a network of partners. And we have mobilization campaigns that happen through social media, broadcast media, and other marketing channels. And once the patients have been mobilized, we do have a screening activity. And the screening activity usually happens at different service provision centers. And for that, there is mobile clinics, we have satellite clinics, there is the main hospital, and then that's the first bit where we see telehealth coming in. Once patients have been screened, they usually the second phase where we have interventions that can happen at the outpatient centers. And for us, that includes physical rehabilitation, provision of mobility assistive devices, and those also can happen at these centers of service provision, mobile clinics, the satellite clinics, and the main hospital. And again, telehealth is a platform that comes in at this particular level. And then we have the third phase of intervention, which includes the services or intervention ways that can only happen when the patient has been admitted to the hospital. And that only happens at the main hospital. And then last phase of our patient journey is follow-up, and that speaks to everything that happens after the intervention. After we've done surgery on a child, after we've given a child a mobility assisted device, the follow-up phase is what happens, and we are able to do follow-ups through our mobile clinics, we're able to do follow-up through our satellite clinics, and we are also able to do follow-up at the hospital, and telehealth again comes into this phase. Next slide, please. Now, having looked at that patient journey, we're able to think in terms of how do we fit in technology? How do we fit in technology to be able to optimize outcomes? Because the patient journey is basically what dictates the outcome of any intervention that we're able to do. And when you look at the right, there's a map of Kenya populated with some green dots, and those green dots basically speak of the mobile clinics that I've been mentioning that we're able to offer some of our interventions towards. And so our first thought in technology is how are we able to replicate this patient journey so that it applies to as many children with disability as possible. And so telehealth was able to speak strategically to that in terms of being able to increase the hospital's coverage in terms of impact. And the other thing that you think about when you're thinking about optimization is resources. And for us, resources comes in 2 ways. Resources that the hospital is using to offer the services that we offer to the children that we serve, and also the resources that the families of those families are putting into the patient journey. And looking at both, being able to save on those resources counts, because every coin with the underprivileged children that we serve, every coin that they put into the patient journey should count for a lot. And how you look at it is, with telehealth, we're able to have a surgeon probably doing surgery this hour, and the next hour they're giving an healthcare talk to different families that are probably 200 kilometers away. That saves the hospital resources, and at the same time it saves the patient the resources in that there is no need to travel to the hospital. The other thing that we're looking at when we're looking at that patient journey, looking at how to optimize it, we're looking at using technology to increase convenience of access of our services. And also that ties in closely with mobility challenges. Now, for the population that we serve, and that is children with physical disabilities, mobility is a huge barrier to being able to access our services. And so telehealth comes in that saving a child that trip that they could have avoided in terms of making that trip to come all the way to the hospital, and probably being able to get part of their services online is a better way of handling the whole situation and lessening the journey, and at the same time making it more convenient for those children to access services at our hospital. And all those points add up to us getting a better intervention in terms of outcome of what we do at Cure Kenya. Next slide, please. So again, having in mind the patient journey that I just shared, what we were looking at is, as Cure Kenya, also being able to come up with a journey into our telehealth implementation process, looking at where do we start and what is the future of it all. And looking at that, we put up some milestones that we were looking to achieve with telehealth. And one of those is, if you remember, the first phase of the telehealth, or rather the patient journey that I shared, is that because we have a lot of practitioners going out there in the remote parts of the country to just be able to see those patients, how are we able to digitize that experience, that when they go there, they're able to retrieve information about a patient and input data digitally and remotely. The other thing that we're looking at just being able to achieve is using telehealth for healthcare education. And especially in what we do, it's a very important part of what we do, just being able to educate people, families and communities about disability, creating awareness so that we are able to educate and remove part of the stigma that exists about disability. And then the second milestone that we've been looking to achieve is practitioner to practitioner use. You remember I mentioned about referrals from a lot of our partnerships, and being able to create a platform where when a patient is being referred to us, there is a platform where our practitioners and practitioners from our partner hospitals are able to collaborate together in a platform, saving the child probably a physical trip to the hospital, and the way forward for the patient is able to be agreed on. And then when we look at the next phase is where we're looking at a platform where every patient that can benefit from our services is able to reach out to us digitally. Probably somebody who needs physiotherapy is able to reach out to us. We're able to walk with them through the journey digitally, having minimal visits to the hospital, and even things like doctors' consultancy are able to be done on the platform. And then lastly, we're looking at the advanced bit of telehealth, where we're looking at automation and collaborative real-time management of patients. I know some hospitals actually already here where you're able to have even surgeons from different hospitals, probably across the globe, collaborate on a surgical procedure as it happens in real time. And so that's kind of the milestones that we look to be able. A lot of, actually, part of this we've already been able to implement. We've been doing webinars on healthcare education, and being able to reach out to thousands already of children out there in terms of healthcare education, and also in terms of being able to digitize the patient journey. Next slide, please. And just lastly, to speak on the implementation challenges that we've been able to face. And one of the biggest challenges that we continue to face as we walk this journey is just patient and practitioner bias, where a lot of our patients and a lot of healthcare practitioners are not yet willing to embrace technology as a tool that they can use in their everyday work life and in their everyday experience. And this probably will continue to change as technology becomes part and parcel of everything that we continue to do. The other thing is, which probably speaks to culture, is lack of trust on non-face-to-face channels, where we find that a lot of patients, when they're trying to seek healthcare, they trust when they have the doctor there. They're able to express themselves, and get to see all the communication ways in terms of gestures and all that. And so we're still getting a lot of that, even in terms of WhatsApp and phone calls. People still don't trust technology when it comes to it not being face to face. And the other thing is, when it comes to telehealth, you don't just drop all that you've been doing in terms of technology and put it away and bring in all new technologies. And what that has meant is that we've faced some challenges when it comes to compatibility in terms of systems that we've been using in the past, and now trying to build that into a new ecosystem where we're looking to integrate all these communication channels into what we had before. And also closely tied to that is the hype illusion, where we have vendors of telehealth everywhere, where they've been hyping telehealth and telling you that it's going to do this, it's going to change the game and all that. And I think the realistic way of tackling this is just being able to come together as stakeholders in terms of, and looking at your patient journey as an institution, and looking at how do we have something realistic that supplements what we do, that helps us grow our impact. And then lastly, when you look at a lot of the developing countries, there's a lack of policy and regulatory framework for telehealth. And in Kenya right now, it's just being developed. And, those frameworks speak to the minimums you're able to do in terms of data security, in terms of privacy, in terms of data storage and all that. And so that guidelines for the whole country lacking kind of presents a challenge. So that's in brief kind of where we are going and where we've come from as Kio Kenya in terms of telehealth and trying to optimize the patient journey. And for us, we look at it in terms of technology is a tool that we're using to be able to grow our impact every other day, to be able to serve more people, and to be able to just be more efficient in what we do. So yes, thank you.
Right, another great presentation, Nelson Woki. Thank you very much for that insightful presentation on technology. Ladies and gentlemen, all too soon we have come to the end of the presentations. We managed to save a few minutes to add to the number of minutes that are allotted to the Q&A session. And so we will go straight to the Q&A, but before we do that, thank you to all the presenters for the great job done. We have questions for all the presenters. Now, for Dr. Selby, does the insurance work better in urban areas or rural areas or both? If there's lower demand for services in an area, do the health facilities still receive payment? That is a question for Dr. Selby. Is Dr. Selby still online? Well, let me help address that question. So the national health insurance in Ghana does not have limit. As long as you hold the card and it works, it's active, as Dr. Selby said. Everywhere you go, you'll be provided the service, provided the facility where you take it, whether in rural or in urban center, is accredited or credentialed by the National Health Insurance. And so it is irrespective of location. As long as you hold the card, you will be given the service, and it works perfectly well. The other part of the question, which is seeking for demand, if there's lower demand for services in an area, do the health facilities receive payment? So the National Health Insurance in Ghana payment is based on claims that you submit. So in other words, if for a particular month you see 5,000 clients, you submit 5,000 claims to the National Health Insurance and they pay for it. And equally so, if you receive 100 clients or 50, you submit claims of 50 to the National Health Insurance and they will reimburse you for the claims that you have submitted. I hope it answers the question. The next question goes to Dr. Sunil Anand. What surprises are you encountering in implementation of your technology? What is the biggest hurdle? Is it the design of the app, the training on its utilization, or getting people to use it, or making use of the data at the back end? So Dr. Sunil, what are the surprises or difficulties that you're encountering with the use of the technology? Is it the development or the design or the usage or getting the data from the back end?
Thank you. Thank you for that question. I think it's a very interesting question. As of now, the hurdles, the major hurdle is COVID. We're at a stage where the platform has been developed. We are also at the stage where we are actually validating it in the field in two settings as of now. Validating in the hands of government health workers here in India, which are the ASHAs and the ANMs, in two primary healthcare centers, because then comparing that with validating the use of the platform by community workers, locally trained women in the northern state of Bihar in India. So the government health workers, we're doing about 12 people, and then in the north, in the community health community members, we're doing about 130. So we're still in the stage of validating, but I think what we are learning is that the digital literacy or the digital lesser literacy among the grassroots level health workers is a challenge. Is a challenge to actually use smartphone, and this is basically Android-based platform, and therefore that's one issue in terms of the literacy levels, the actual literacy of the person as well as the digital literacy of the person is one aspect that we are considering. And we are also involved in studying, what are the ways in which, what are the major hurdles that are coming that are related to literacy. And two, and we've devised a training program for these frontline workers. Most of them have done, studied up to standard 10. And therefore, the training process itself is a learning for us. So I think, when this validation process comes to an end in another 3 to 4 months, COVID permitting, then we will have answers to, what are the major hurdles and how do we overcome those hurdles. I hope that helps.
Right. Thank you very much. So I've seen that. Thank you, Sunil. So challenge literacy for the users are challenges, but yes, obviously after your pilot, you'll be able to provide more information. Thank you very much. I see Dr. Selby is back. Thank you very much, Dr. Selby, for your time. I know you are at the World Health Assembly preparations. We have a question for you. I want to throw it back. So someone wanted to know whether the NHIS in Ghana works better in urban or rural areas or both. And the follow-up question is that if there's lower demand for services in an area, do you pay the facilities in those areas?
Thank you very much for the question. Health insurance, I think, works better in rural areas in Ghana for several reasons. I think the rural folks appreciate it more. The urban areas, there's almost a belief that health insurance is for the poor, and you don't want to be seen as poor. So you want to do your own thing, pay cash, get private health insurance or something. Whereas in the rural areas, they actually appreciate it. So it works better there. Now, talking about if people don't come to your facility, that is a major challenge for us. What we have found is when facilities are crowded in an area, there isn't enough work for them to do. And then to maintain their facility, they take top-ups from the patients, illegal payments, and I'm afraid the temptation to even put in claims for patients who never attended becomes very huge. It is one of the challenges we're battling. We are now doing, we're almost there, facilities mapping, to try to use the power of the credentialing and contracting to encourage people to move into underserved areas. The reality is health insurance for most facilities makes up 90% plus of their patients. They don't have that many walk-ins anymore. So if you are not getting health insurance patients, you are not viable, really, unless you're a very big facility. So we're trying to use kind of the financial levers of our social health insurance to get people to move into underserved areas. But people don't like change. It's a challenge, it's a dialogue, but no, we don't pay for no work done. Thank you very much.
Right. Thank you very much once again for your time. So we have two questions for Paul. Your first question is that many of us are now getting to know about the Bloom Library. Can we post information to it from our own work, or should we coordinate with SAIL on that?
Thank you for that question. Anyone can post to the library. It's a function from within the program. We would be delighted to have a dialogue with any of the health associations or providers that want to post information so that we can help you consider the best ways to present your information and share it. But it is user-generated content. So anybody that wishes to and uses the Bloom software on their computer can upload books.
Right. Thank you very much. You have a second question. How do you make sure language is an appropriate language that is used is at appropriate educational level?
Well, that is a challenge, and it's more of a process as material is being conveyed. You need some people that are not thinking in terms of the medical issues, but in thinking in terms of the audience and how they use language. So you really need a kind of a team approach of people with the special knowledge, people that are good with communication, and people that are familiar with the audience, and then do testing with people that you would like to have receive the information and check to see whether, after they've read it or it's read to them, can they actually understand it? Can they answer questions accurately? They should understand from the resource. So there's kind of a process that you could follow that will help ensure that that happens.
Right. Thank you very much, Paul. We have a question for Nelson. Often patients go to the hospital to get drugs or treatment, but sometimes supplies do run out. Can digital help inform clients about stockouts or gauge medicines that are needed in advance?
I think that's a really good question, because one of the key users in terms of technology, and just not in healthcare, is managing of procurement management and logistics, where technology is able to monitor things like stocks, probably in a hospital, and inform the concerned stakeholders when there is need for refills. So looking at it from the point of view of when the hospital is monitoring probably a drug that the patients collect probably on a frequent basis, they're able to probably use technology to join the supply of the drug, the hospital, and the patient, so that when there's low supplies of the drug, the supplier knows when to restock. And also, that actually makes sure that the patients never run out of the drug. Or probably if a patient is due to collect a drug, they're able to get a notification on whether the drug is available or not. So I think, yes, that's a very legit application of technology in terms of just being able to regulate all that.
Yeah, so I think it would be fantastic if healthcare facilities will truly be able to put data out there. But I think the biggest question is, if I tell my clients that I have paracetamol that will only be able to serve 50 patients, then the question will be, am I going to be the 51st patient? What if 50 patients have gone there already? They will be taking the medicines. So in many ways, I mean, healthcare facilities will be shooting themselves in the foot by saying that don't come. But that is a double-edged. Whereas it will benefit the clients, it may not necessarily benefit health facilities. And I wonder what facilities will be able to do that. But that will be a good information to have nonetheless. Right. We have another question for Andrea. Are there examples of integrating physical, social, and spiritual in digital messaging?
Yeah, that's a great question. I think what we find is our partners who are faith leaders do that quite naturally. And so a lot of our content was really generated by our pastors and faith leaders themselves. And so very often you would see kind of a daily note that would have a message like wash your hands, and then a YouTube video of some sort of worship song or prayer or encouragement from the scriptures. And so I think when we partner with our local faith partners, they do that naturally. And so I think the messages were almost all integrated in that way. Great question.
Right, thank you very much, Andrea. You have a follow-up question. Someone says that, in what ways do you think previous engagement with faith leaders in global health objectives such as family planning, HIV, maternal health, laid the foundation for the role of faith leaders played in disseminating COVID-19 information?
Yeah, that's a great question. I think I would say there's a few things. One is just pre-existing relationships of trust. And so one of the things we saw, especially in COVID, when there was so much information coming from so many different sources, having a trusted source and a relationship with local faith partners really made a world of difference. So they knew we can trust our World Vision health professional colleagues because we've been working with them over time on a number of these health-related issues. So I think that's first. Second, for us, we had sort of a methodology for engagement with faith leaders, recognizing the importance of religion and scripture and theological roots in dialogue and informing how we make our decisions as people of faith. And so I think understanding that the need to communicate, kind of related to the last question, with a unique blend of both health and technical information, and addressing the theological questions, concerns, and creating space for that dialogue to happen with faith leaders and their peers, with pastors, as they work through some of those barriers, is really essential.
Right. Thank you very much, Andrea. Nelson, we have two more questions for you. One says that, are there legal constraints in lower middle income countries which should concern telemedicine compared to what we have in high income countries?
I think to answer that, one of the challenges I highlighted with regards to implementation of telehealth, especially in low and middle income countries, is that for a lot of them, there's lack of clarity in terms of regulation. And when you look at, probably giving an example of Kenya, when you look at Kenya, the only regulation that I see, legal regulation that I actually see that touches on that, is that, there is some guideline that hospitals in Kenya cannot store data outside the jurisdiction of Kenya without permission of Ministry of Health. But it doesn't say much about, patients being able to consult online with doctors who are in another country. So right now, there's a lot being developed in terms of regulation, which would have legal implication. But currently, there's not much that brings, all that clarity into it.
Great. You have another question. Do you have experience of drones that are used for dispensing medicines to patients?
So in my experience, I do not yet have that experience of drones, but yeah, I've seen hospitals being able to do that, use drones. And I think it's especially for healthcare organizations that are working with audiences that are in very hard to reach places. I've seen organizations using drones to be able to deliver vaccines and all that. But in my experience, we've not had that experience in our organization.
All right. Thank you very much. Now, there's a question that I want to put to all the presenters here. What do we see as opportunities and gaps that, faith-based organizations face? Do we have opportunities to use technology? Are we optimizing all those opportunities enough? Are there gaps in using technology for faith-based organization? If there are gaps, what are those gaps? And compared to the public sector, are faith-based organizations paying more attention to technology? This is an open question. We want to throw it to all the panel, all the speakers. Dr. Selby.
Thank you very much. I would like to take this opportunity to actually praise the faith-based providers in Ghana. We gave the opportunity for electronic claims. All our claims used to be manual, and we've tried to go electronic. And I must give credit where credit is due. The faith-based providers in Ghana went wholesale electronic. And it has given us a lot of data for us to take decisions on. So I'll praise them in that regard. They've done very, very well in Ghana. Thank you.
Thank you very much, Dr. Selby. Very grateful for that. Yes, Andrea.
Yeah, I think one of the things I think that we learned in the past year is that more is possible leveraging technologies like WhatsApp than we thought. I think we assume, especially when we're talking about kind of grassroots community engagement and the opportunity, and talking about tough issues, you know, so when we talk about vaccines, for example, some of the barriers to vaccine uptake, having those difficult conversations, I think we've assumed for a long time that we really need to have these face-to-face opportunities to engage, and technology has seemed too impersonal and too like I think we've made some assumptions about what we can and can't do with technology, and we've seen that it's hard. It can be really hard, and we're building on pre-existing relationships. So I think I still have a lot of questions. Can we start relationships using mobile technology that are able to get at some of those kind of barriers to changing behaviors related to health? I think that question is still out, but I think we have learned there's a lot more we can do, and I think we're a lot more interested in kind of experimenting and trying things as we move forward. And so I think it's a huge opportunity, and especially in the post-COVID world, whatever that is, when we can have some face-to-face engagement, but then also really leverage technology to further that. Thanks.
Great. Thank you, Andrea. Paul, I saw your hand was up.
Yes, thank you. Just a couple of fractions on technology. I think an advantage that faith-based organizations have is with their connections to churches, they can have a fairly accurate sense of the technology that is available to people, because those who get excited about technology often think of possibilities that don't reach where people actually are, and want to use things that you have to have a smartphone for, or you know, the things that are beyond the people you're trying to reach. So I think you should take advantage of that network to find out what technologies are realistic and available. But I think also we can use our networks with other organizations to learn from those who are using technology more, and to use like CCIH as a place to find out who is, like we've done today, who is using what technologies in what ways, and let our collective experience give us ideas that we can try, so that as an organization, you don't have to be expert about using modern technology, digital technology, because you can learn from others who've done more, been ahead of you in that game. So I think there's two ways that we can take advantage of the networks that we're embedded in, both for technology possibilities and also realities on the ground.
Fantastic. Dr. Sunil.
Thank you. I think I'll start on a positive note. I think we have faith-based organizations have a lot of advantages in actually translating technology to meet the needs of the community, because one is because of our work and our linkages and networking with at the grassroots level, we faith-based organizations have better understanding of the realities at the grassroots level, and those realities with their challenges are an opportunity for us to be able to think out of the box and look at solutions that are not run of the mill, because most solutions seem either beyond our reach or have been tried and tested and have failed in many areas. The second advantage is that of networks. We have a huge amount of networks, and how do we capitalize and how do we build on those networks, both within the community as well as in other organizations. The third, of course, is the reputation that faith-based organizations have in the community, that the faith-based organizations are more concerned with the welfare of people, with providing quality services, and therefore that the use of technology then becomes an advantage for faith-based organizations. Just going to one or two aspects of on the gaps. One is I think we probably need to look at the capacity of faith-based organizations. We are so focused on delivering service that we don't look at innovations, or we don't look at initiatives, or we don't look at different ways of doing things, so that that can set us up to leverage technology. Second thing is, of course, is basically as far to me, it's the mindset. One is it's this mindset that we are involved in actual work on the ground, so why need technology at all? The second mindset, of course, is why do I need to collaborate with others? But I think there's a lot of merit in considering collaboration with whatever organization, as long as technology translates into something good for the community. Thank you.
Great. Thank you very much. Now, I would like to go back to the questions. But before that, so I see that technology actually holds a lot of opportunities for faith-based, especially, I know that in many countries, many of the Christian health associations work in rural areas. And one big area where we have big opportunity has to do with access to skilled personnel. I know that in Ghana, even for the Ghana Health Service and CHAG, you can't have obstetrician gynecologists in some critical areas. One way that we can make their skill available is, for instance, using WhatsApp platform, where health professionals in these rural areas can, communicate with obstetrician gynecologists and other surgeons or other skill outside those areas to get some real-time information on how to handle cases. Another area has to do with improving referral system, for instance. So we can use technology to inform facilities ahead of time and prepare them to receive referral cases. I think where there's challenge that I see is when it has to do with, say, children and teenagers. Much as information is quite essential in using technology, sometimes too, you never know what children can use. For instance, mobile phone that is present in almost every home. Excessive use of mobile phone for children can lead to something else. They can have access to certain information that, if not regulated, becomes another challenge that we solve. I think a huge, opportunity lies also in preventive medicine. So in fighting COVID hesitancy, for instance, we have done quite a lot with messages that are sent on WhatsApp to communities and what they should expect and all that. That's great. The dilemma, which is not only to faith-based, but it's public health dilemma, has to do with, now, if we are able to reach more people by technology, what do they pay to sustain the system? How do we, I know that in Nelson's presentation, he said that it lowers the cost of access to health services. And so you can have more people accessing technology and in terms of prevention, but then how do you sustain the services that you are delivering? More people are used to having more patients come to the facility level. And by that, you have more insurance claims or people paying for the services. So you are able to generate enough to sustain the service. Now, if you reach more by technology, by way of prevention, how do you sustain? Those are questions that I know health managers ask. But let me go back to some of the questions that we have before we close. So Nelson, what is your experience in teaching some skills or procedures like mobilization of lymph through telehealth?
So so far we've done quite a number of trainings online, and our experience on that has been that and I think this for us was accelerated by COVID, because before COVID we'd do a physical training, and when COVID came, we had to, innovate. How do we still go ahead with those trainings? And I think because kind of everybody knew the limitation that had been presented by the COVID situation, a lot of our trainees were very receptive to the new way of training. And we actually were able to do quite a number of trainings, doing a training a month, as opposed to when we had been planning those trainings physically, which we couldn't be able to sustain a training a month. And so one of the things that helps with online training, you're able to share probably materials beforehand. You're able to have people go through the materials. You're able to take questions, beforehand. Just like this conference that you're doing, we're able to take questions and probably get in touch with those participants after. And there's all these innovative ways of being able to engage with people. The other thing that, kind of facilitates that is the transition between before, during the training, and after. Because, using WhatsApp, we're able to create those platforms. We're able to create platforms for trainers in a particular location. And the engagement, because kind of started online, is able to continue even way after the actual training has happened. So that's one of the things that's part of the experience that we've had with online training. But yes, it presents its challenges, but it also presents its opportunities.
Right. I know we are running out of time, but we have general questions for all the panel members. In terms of advising others who want to implement technology used, what will be your number one recommendation? Or what will be your first step to implement technology that you used? This is a question that is open to all of us.
I could take a first step. I think just do something. Start small. Do something that makes sense. I think sometimes, at least for me, I think for us, we tend to think, what is the comprehensive technological solution that we can bring to X problem or Y problem, and then we get into these long-term projects and whatever. And I think one of the things, again, that we learned is we already had these very simple informal WhatsApp networks, and those could be leveraged and taken to a new level. So look at what's already working, and do make incremental changes. Try it out, get some small wins, and then start to build on what's going to be most effective and strategic to deliver your long-term goals.
Yeah, I like the bit about small wins. Small wins are quite important. Thank you very much, Andrea. Dr. Selby, I see your hand is up.
Thank you very much. I will support what Andrea has said. Technology tempts you into big multi-million-dollar projects, and often they are not necessary. But I think technology for technology's sake is also a trap we all fall into. What you must do is identify your problem and think it through, then find the technology solution to fix it. But we're all tempted to use some technology, even if without thinking through the problem we're trying to address. So I think my thought to everybody is identify your problem first, and then find the appropriate technology solution to fix that problem. And don't think of multi-million-dollar projects and contracts. Sometimes the simpler things work better. Thank you.
Right. So resist the temptation of thinking millions of investment into technology. First, identify the problem. Look at what works. Let's consider the small wins. Ladies and gentlemen, that brings us to the end of our session. It's exactly 2 o'clock our time. On behalf of CCIH, I want to thank all of you, the presenters, and also those who asked questions, and those who could not ask questions because of time. Thank you very much. I want to hand over to Mona. Thank you.